tissue models for you to practice these procedures on. You're going to do suturing. We're going to cover a few of the most common suturing techniques, and you guys will also perform some injections. I think we're going to use pig's feet, if I remember right, so it gives you, better than what like a normal mannequin is, which is rubbery and not as close to like a live tissue model. But so you guys will practice it on those days. We're going to cover all of it here today, and then we'll watch some videos before we do each of those suturing techniques, and then you guys will get hopefully a lot of reps in. You get out what you put in, so it's going to be up to you guys, but we're going to be here to guide you during that lab. And I think it's a surgery/derm lab. All right, so we'll talk about the different instruments, what supplies you need, the different types of suture material. We'll also talk about what sort of documentation you need, consent forms, stuff like that. All right, so sutures. This is obviously a very common procedure you guys are going to be performing, probably in phase 2 quite frequently, especially in the emergency department. You'll do it in your outpatient clinics, not as frequently, but it will be something you have to be proficient in, especially when you guys are like forward deployed or at any of the training centers, things like that, where you don't have an ER for them or an acute care clinic they can go to. You guys are going to have to be the ones guiding this. You're also going to have to be the ones, 15 months from now, whenever you guys graduate, you're also going to have to be the expert that teaches your medics how to do this as well, or you have to do all the procedures, which, is great, but obviously you may need some help, so you're going to have to be the experts eventually. So suture, it is a foreign body, so it does have some side effects, even though we're using it to close up whatever that laceration or wound is. Your body does have an inflammatory response to the sutures that are placed there. So it can interfere with wound healing, and it can increase risk of infection, which is why we're going to talk about the different sutures that we use and what they can and can't be used for. So obviously we want to use the minimum necessary sutures to close that wound, give it a good cosmetic outcome, and reduce infection. So basically, there are different types of materials, so some of them are going to be absorbable, some of them aren't absorbable. We're going to talk about some tensile strength, so the different types of sutures. The larger the number, the smaller the suture it is, the less tensile strength it's going to have, the smaller the diameter. So some of them are going to be a little bit harder to work with than others, which is why you guys need to practice a lot. We're going to give you some sutures on the minor procedure day, and you're going to be like, I can't tie with these, I keep breaking them. Well, that's why you're practicing. Keep practicing, keep tying them until you can. So I know a lot of you will want to revert to larger sutures during that training, but the best training is going to be with the smaller suture size, so that you can get used to tying them without breaking those lines. So we have different configurations. So we have braided, like people who are fishermen or women. So like your braided line obviously is going to be stronger, however it increases your risk of infection. Most commonly we have a monofilament line that we're going to be using. In the monofilament we typically tie 5 knots, and we'll cover that during our videos and our practice and how many knots you guys are tying. All right, so here are the different types. So we have absorbable versus non-absorbable, and then braided versus monofilament. Typically, the braided has a higher risk of infection, however, it's a lot stronger. So you'll most commonly see the braided materials done for chest tubes when we suture those in. And that's typically with a silk or a zero silk, which does have a higher risk of infection. However, it's a lot stronger of a material. And then, like I said, the size of the suture. So like a 3/0 is smaller than a 2/0. We don't like to make things easy to understand. So the larger the number, the smaller the line it is. And then you have to pay attention to what type of needle it has on it as well. So So it's important to look at your suture packages and what you have and whether it's like a tapered versus a round versus a swage needle. And we'll talk about which procedures we use those for. All right, so here's our different types of needles. So we have a cutting needle, which is probably the most common one you guys are going to use, especially for like suturing, lacerations, and things like that. Then we have our tapered or round needles, which is when we're doing delicate procedures in the body, like blood vessels or we're ligating blood vessels. Then we use it for the bowel as well. Swage just means the suture's pre-attached to the needle. Most sutures, or almost all of the ones I've ever used, are attached to the needle already. And then you can have like your double arm, which has a needle on each end, which you can use for anastomosing blood vessels or bowel. You'll also have in your guys' medical equipment sets, you'll sometimes have two needles for certain chest tube kits, depending on which ones you have. So it's important to open those up and play around with them to see what you're working with. All right. So like I said, you got your different suture lines. Most commonly is monofilament is what you guys are going to be using for like your laceration repairs and those minor procedures that you're doing. And then you can have those braided lines, which typically hold a better knot, they're stronger. And those are ones like we use for chest tubes. Then we have our absorbable, which is typically your gut or your Vicryl are the most common that you're going to see. There is monocryl as well. We don't, typically, if you have it, great. If you don't, your other options are usually a Vicryl is probably the most common one that you're going to see. And then your non-absorbable, your Prolene and Ethylene are the two most common that you're going to have. All right, so needle drivers. This is what you're going to use for obviously placing those sutures. And there's a difference, so I have some examples. And there's a certain way to hold it too. So you see how they're holding it there? Like, this is a needle driver. It's hard to see, but we'll use them. These are hemostats, so they're different. This isn't a needle driver, this is. So you got to pay attention to which one is which. But how you hold it is with your ring finger and your thumb, and then you have your index finger to provide more support for when you're performing these procedures. So what we don't want to, and obviously you have a lot more tactile control if you're using your ring finger. So this is how you hold it, okay? Don't hold it any other way. All right, it doesn't work as well like this. And I know some of you have banana hands, and you may have to, we may have to get different instruments for you, or it may not be as comfortable, but that's how you're using these, okay? And when you're suturing, you're just like turning the doorknob. So you want to load the suture usually like halfway, usually like, half to 3/4 of the way. You have to think about if you're closer to the needle end of it, it does have a cutting needle, so you could dull the needle depending on where you're placing your needle driver at. So something you guys need to pay attention to, and we'll help you during the practice, and we'll tell you you're holding it like a caveman or something, and that's not how you use it, and we'll correct you like 50 times and then give up when you don't do it right. I'm kidding, kind of. All right, then we have our tissue forceps. So you hold this one like a pencil, so this is how you hold it, okay? You're not like a toddler learning how to use a fork like this, okay? You hold it just like you would a pencil, and I know some of us hold pencils differently. This is typically how you use it. You have basically more tactile control with it that way. Some have the little teeth on them for better retraction, like these ones have teeth on them, so they can help grasp the tissue. However, you can damage the tissue as well, so you got to be careful when you're using these. And then we have different instruments for inside the body, which you don't need to know the difference between them. You need to know the needle driver, forceps, and then what hemostats are, because it's not a needle driver, and you'll realize that when you're trying to use it and you think it's a needle driver and you're like, this isn't working very well. Well, that's why, because it's not a needle driver. And it's important as well because sometimes you won't have suture kits, hopefully you do, or you have to make them yourself. Like the MES sets don't come with actual lac repair kits, it just comes with a bunch of instruments you throw together, and your medics probably aren't trained in it, so it's important you guys understand the difference between these types of instruments. All right, so our suturing technique. So we want to avoid closing wounds under tension. Typically, we like to have some sort of tissue eversion, which helps the healing process. And then we typically start with our suturing method. We place one in the middle of the wound, and then we just middle space our sutures after that. So you got one in the middle on the right side of the wound, place one in the middle on that. And then you may need one or two more on the outside, depending on how large the wound is. And as you can see in the pictures there, one wound has, 50 sutures on it, and one has a lot less. So typically you want to use the least amount possible to create tissue eversion and to close the wound without any gaps in it. All right. So like I said, needle perpendicular to the wound, you're coming in, and then you're turning it like a doorknob, and hopefully you can get an entire bite with this through that wound, and it comes out the other side like you see on the sutures there for your tie. So you're going to drive the needle in, and then once it's on the other side of the wound that you're trying to close, you need to do what we call a surgeon's knot. So that's a double loop knot to start with, and that's going to create the tension you need to place the usually up to 5 knots on it. So a lot of you are just going to do like a simple one hand overhand throw, and it's not going to lock in, and that's why. So you got to do it twice. It's what we call a surgeon's knot. And it'll make more sense when we show you the videos. You don't have to, remember all this now, but just pay attention to the videos during the procedure lab, and then you shouldn't have any problems. If you do, it's because you're not placing that knot appropriately. One of the things, like a good rule of thumb or practice is, if it doesn't look appropriate or you don't like the cosmetic look of it, just take the suture out. It's that easy. Just cut it out and put another one in. All right? And you can do that on patients. They won't even know the difference, and you just pretend like you're doing everything normal. But if it doesn't look good, you need to fix it. All right, there it is. Turn it like a door handle, like I was telling you. A lot of you will want to come in and kind of push it through, but really it's designed to just turn it like a doorknob. All right? And we'll get plenty of practice. All right, so like I said, load the needle, usually halfway, sometimes 3/4 of the way back from the needle tip. Then you want to insert it at 90 degrees, and then, turn your wrist or roll your wrist, and then pull the suture through. You have tissue forceps, so sometimes you have to grab the tissue, depending on how large that laceration wound is. And then you need to approximate the edges so that you have good tissue eversion. Every wound is different, so no, there's not like it needs to be this distance from the wound. It's all cosmetic outcome and how that tissue, the eversion looks when you're doing this. And then the do nots are going to be what you're doing when you have problems trying to suture. So basically, you didn't load the needle right, which a lot of times happens, and you might be too far forward. Sometimes you're using those really small sutures, and so the needles are going to be a lot smaller too, so that's something you need to think about. Those typically we use on the face and those cosmetic areas. So that's going to be some of your problem as well, and your needle driver is going to be maybe too large for it, but you guys will find a way. All right. So the technique we're going to use most commonly is a simple interrupted. So you guys need to master this during that minor procedure lab. So this is just, you place one suture, tie it, and then you continue on. Like I said, usually start by cutting the wound, basically using your first suture halfway through the wound, and then use half on each side. Most sutures are left in place, like it says, 7 to 10 days. The face you can do a little bit less just because it's a lot more vascular and it's going to heal faster. And then we want to move all of those knots off to the side of the wound. We don't want them midline, and we usually pull them all to the same side of the wound. So, all on one side or the other, doesn't matter which side, but just cosmetic wise, that's how we do that. All right, so here are the other two you guys are going to be mastering during that lab. And simple interrupted is the most common. You can use it on almost anything. However, you may need to use these mattress sutures, which go a little bit deeper, and they provide a little bit better eversion. So if you have a larger or deeper wound, you may have to use these because a simple interrupted isn't going to have enough tension on the wound to close it. So these are going to be your other two techniques we're going to practice that day that you need to master. And like I said, larger lacerations, deeper lacerations, it does better with the wound eversion. And then these ones typically, because it's a larger area involving, maybe involving a little bit deeper than your dermis, so they're going to stay in a little bit longer. So typically we don't have to use these on the face very commonly. Scalp, we typically use staples just because it's a little bit easier, and we're not worried about cosmetic outcome on those. And so you have your horizontal versus your vertical mattress, and it just depends on what type of wound, but typically the vertical is going to be for wounds that are under a lot more tension, and you're not able to get eversion with your other techniques. But it does take a little bit longer to place these. All right. So we have plenty of other suture techniques. I think your running suture is another common one. We use it a lot. You'll use it during your during your surgery rotations. Commonly, we're not using these in outpatient or emergent settings, the running suture, but you're really just using one suture to run the whole length of the wound to close it. It's a little bit harder to learn than like your simple interrupted. It might be easier than your mattress techniques, but this does have a higher risk if that suture line breaks anywhere, you're going to have dehiscence of the wound. We also have what we call our running subcuticular, which you're using absorbable suture, and basically all of the sutures are buried in the wound and you don't see them. So that's probably one of the harder techniques that you use. However, some of your surgery rotations, you'll be running like a minor procedure clinic with somebody, and this is what their preferred technique's going to be, and you'll have to learn it and master it. It's not hard. You just have to remember where to bury the different knots in there when you're doing it. But it's not something we're going to practice on suture day. Now, if you're more advanced, certainly you can practice this, but we're going to recommend you guys master the basics first. Those are the videos we're going to watch when we're performing those procedures. We're not watching them today. They're like a minute-long videos. They're phenomenal. You guys will want to save these for when you're training your medics as well, so you have them in the slides. It's just the Duke Suture Skills Lab. You can Google it, or it's on YouTube. Very great 1-minute videos. How to tie the most basic knots. We'll watch them multiple times. And there are some of the deep dermal techniques that we use for certain wounds that, are a lot deeper, or that, procedures we did where we had to remove some sort of lesion that was deeper in the tissue. If you guys are going that deep, though, in your outpatient clinics, you probably need to question what procedure you're doing. All right, so you guys will definitely be removing a lot of lipomas in the outpatient clinic, like epidermal inclusion cysts, ingrown toenails. You will remove some like nevi, moles, and skin tags, especially ones that are causing irritation. Typically like in the axilla, along like your neckline, and some of your like intertriginous areas as well. You'll commonly remove these in clinic. All right, so what do we need to do beforehand? Just like we talked about, we need to do our little pre-op physical on the patient. So you want to get that focused history. You want to know what medications they're on. Are they on anticoagulants? Anything that's going to increase the bleeding risk. Then we have to get consent from the patient. So we need to explain to them, hey, here's what we're doing. Here are the risks with this procedure. Obviously, bleeding, infection, injury to other structures are the most common ones. You might have a poor cosmetic outcome. Then we need to explain to them the alternatives, like, hey, if we don't do anything for this, here's what can happen. Like, a lot of times patients will want lipomas removed, but it's not, most of them don't require removal. most commonly you'll remove them in areas that cause friction or maceration, like with body armor or rough sacks, things like that are going to be common reasons you're going to remove some of these lipomas or cysts on patients. And then we do need to perform a timeout prior to any procedure. And it's required for your documentation too. You'll have to do a procedure note that has a timeout. So it's always good to, monitor the time you're doing the procedure and performing a timeout. Usually for like laceration repairs, things like that, you're probably not going to operate on the wrong side because there's a laceration there. But these are for like larger procedures, and it does happen. I mean, there was a recent one they operated on the wrong side of the brain, which, don't know how that happened, but it does. All right, so how do we prepare for it? So a lot of times you can order laceration kits that come with everything you need in them to include all of your drapes, but you need to plan the incision. You need to get the appropriate suture material. So a lot of times I'll go, a couple packages of the suture, just because sometimes when you're placing that needle on the driver, it might drop on the floor or something like that, and you have to have a backup. You don't want to be like, oh, hold on, let me go grab some more. So, and I usually go with a size up or down as well, just to be on the safe side, in case one's too large or one's too small, or I can't get enough tension in that area and I'm snapping my suture material. So you always want to plan ahead for that. And then you need to prepare the site. So, we do want to use like an aseptic technique. Some procedures are sterile, like your laceration repairs are we use a clean technique, so it's not sterile. But it just depends on what procedure you're doing and what sort of, whether you need it clean or sterile. Typically, like for me in the ER, they say nothing, the surgeons say nothing we do is sterile, so we're typically not doing a lot of sterile stuff there. All right, and then your Mayo stand's another important one. Sometimes you'll have one in your whole clinic, so you guys need to plan appropriately. All right, so we have different blades for different purposes, all right? But we always need to remember this when we're getting a scalpel out. We have different sizes. Here are the most common. You have a 10, which as you can see is that larger surface area razor there. And that's meant for the larger incisions. You're cutting along the surface of the blade or the hump. The most common one you're probably going to use is an 11, and that's for punctures or cutting. Not for longer incisions. You'll commonly use that one for like your abscess, incision, and drainages. You may use it depending on, lipoma or cyst removal. And then you have your 15, which is basically the 10 blade but smaller. So you're making you're not using a puncture incision, but you need to make a smaller incision where a 10 is not appropriate. So it's important you guys can differentiate all of these. And then here's our different instruments. So just be aware, they all go by different names. The most common one you're going to need to know is like your needle driver. You're going to usually have some sort of straight Mayo in your suture kits to cut that suture material when you're done. And then you're going to have your different types of tissue forceps there. No, you don't need to know these for like testing purposes, but it is important to understand there are different instruments for different procedures. Like the one on there is for the toenail removal. It's going to be like the hardest thing to find. So you may have to use other scissors for removing toenails when you don't have the right ones. All right, so how do we prepare for it? So obviously we want in a comfortable position. So typically we like to, we want the patient to be comfortable, but you have to be comfortable as well when you're doing these procedures. So you want to place, you want the patient position so you can comfortably sit or stand next to them and perform this procedure. For some of us, like I always have a little bit of a tremor, so I like to anchor my hand on this field. So sometimes you have to create a sterile field with drapes around it to help better anchor yourself and to keep the area sterile. And then we obviously need to plan it. We need to consider how many sutures we may or may not need for this, how deep the wound is. This is why we explore all the wounds prior to doing any procedure. And then it'll lead to better outcomes. You want to close it on natural skin lines as well. So when you're removing certain lesions, you need to look at the skin lines and think about how you're going to do this and how you're going to make this incision so that it has the best cosmetic outcome for them. And then obviously you don't want any dog ears. If you do, you may have to incise some of that, or excise some of that tissue in the process to make it look good. And like it says, you can do any lips around it. You can, a lot of times we'll draw with one of those tissue markers first to plan our procedure, and they typically say 4 times longer than the width. All right. So to prep the site, obviously we want some sort of absorptive material because there's going to be some bleeding. You're also going to have, whether you're using betadine, chlorhexidine, or whatever sort of prep you have, but you're going to want to clean that area first, usually in a circular motion. And then you're going to drape the area appropriately. And you see how they're draping that square towel? That's how you're going to pull that to create an area around your wound or your operative area. So you're just grabbing each side of it, it's flipping it into triangles, and we'll practice that as well. We also have our not just our procedure lab, but we also have a lab where you guys are going to have to don all this equipment and prep surgical areas. So you'll get practice with all these, and we'll show you how to do it the correct way. All right, so we obviously want to anesthetize the area. And like I said, usually smaller, longer needle, 27 gauge works really well. Sometimes you may have some issues when you're injecting the medication with smaller needles, so you need to think about that as well and how large the area is. Sometimes you can't actually apply enough pressure if you have too small of a needle. Then we need to decide what we want, lidocaine, marcaine. A lot of times we'll do a 1-to-1 ratio. Sometimes we'll just use lidocaine as well. It just depends on what you have on hand. If you're planning it ahead of time, typically we'll mix them. If you don't have that much time, or if you're trying to be productive and move patients, sometimes you just use the lidocaine. And you can also bend the needle at a 45-degree angle to get obviously with the skin laying flat, it can be hard, depending on where the wound is, to angle your needle appropriately, so you may have to bend it as well. So don't hesitate to do that if you need to. All right, so follow your planned incision line. Obviously, you want to incise through the skin. Most of you will, on your first time, you won't incise with enough pressure to make it all the way through the skin. So a lot of you will be scared your first time. You'll make a very minor incision that's not going to be appropriate enough to perform whatever procedure you're doing. But you'll eventually learn what type of pressure you need. That's usually the most common mistake I see on the first time. It's like a little baby incision on there, and it's not appropriate enough to do the procedure. Some of you, for your first incision and drainage, will make a tiny little poke in it. And it'll need to be a little bit larger, especially if you're trying to undermine or get all those loculations out of there. So typically it'll be a little larger than you think. But it's better to start small and work your way to a larger wound. And then if it's an open cavity, obviously you want to use those radio-opaque sponges just in case you have any chance of leaving any sort of foreign body in the wound. Most of the wounds are smaller lacerations or INDs or lipoma removals. So typically you're not going to be using that many sponges where you're worried about it, but it is something to think about. All right. So there are other options we can use as well for closing these. Like we can use steri strips if it looks like the wound isn't deep enough or doesn't need like a primary closure with sutures. Dermabond is also another great one we use all the time. I probably use that the most for lacerations. Works very well on the hands on patient because Band-Aids aren't going to stay on there. they're gonna, especially if it's their dominant hand and you place sutures, it can be irritating. So sometimes, there are wounds that probably can be closed with sutures, but sometimes I'll glue them as well. But that's just provider dependent. You have to make the call. All right, and then you can use staples. So these have a very high tensile strength, and that's why your scalp is very, it's very vascular for one, but it also is very tough. So sometimes you're going to break even larger suture lines trying to suture the scalp. So that's why a lot of times we use staples instead. And they do have a low resist. They have more resistance to infection, so you have less of an infective risk with those. But they're going to create a large scar, and it's not real painful either. Some of us as medics, we might stapled our arms or whatever. I don't recommend it, but you don't actually feel it really even going in. It's painful when you have to take them out. All right. So obviously, when we're finished with the procedure, we need to make sure we counsel our patients appropriately, when to shower, when they can get the area wet, what they need to protect it during that process, especially what date to come back. So a lot of times we'll just say, yeah, return for suture removal. Make sure you guys put the exact date that it should be removed in there. It also doesn't just help you, it helps the provider taking out those sutures or staples and what date should be appropriate. And then the documentation, probably the hardest part. So obviously, if you're sending any samples to pathology, you need to make sure it's labeled appropriately. I know that sounds too easy and silly, but you guys will find out that certain specimens require it to be labeled in certain areas of the location. It has to be there what type of specimen it is, and sometimes these can be difficult to label appropriately, especially if you're just counting on your nursing staff to do it. They may not know, and it gets kicked back, or they dispose of the specimen. So it's important you guys understand what labels need to be on there. It happens a lot, especially with like blood cultures, even common labs that I run to ER or specimens are labeled inappropriately. CSF is notorious for being labeled inappropriately. You'd think it'd be easy because it's CSF and it's in little tubes, but yeah, you need to make sure they're labeled appropriately. Then obviously it needs to have patient identifiers, date, where the location was. And then here's what like your typical procedure note looks like. You guys are going to be using Genesis, so it'll have all of this in there, and it should have a procedure note. Every clinic will have them. You can steal the note. They're usually open to the public, but you can steal the note and save it as your favorites, and it'll all be in there for you to do in your most common procedures. And then post-procedure cleanup, so you need to pay attention to which sort of drapes you're using, whether they get thrown in the garbage versus they have to be re-sterilized and placed in a different bin. Obviously your instruments, if it's not a disposable set, it's going to need to be cleaned and then placed in whatever the designated area is to autoclave it for re-sterilization. Every facility will be different, and they'll explain this to you hopefully, or you'll ask. And then obviously we want to make sure we follow up on that path report. Any complications that they may have, obviously cosmetic outcomes are important. We need to talk to them about scar and what is going, what sort of prevention measures they can take to prevent the scar formation. And then suture removal. So you'll have suture removal kits. Sometimes you won't. You may just have to use a scalpel, but typically the suture removal kits have a pair of scissors and some forceps in them for suture removal, and you just cut them out. The key to remember is you have to make sure you remove the entire suture. If you leave any foreign body in there, they're going to create some sort of inflammatory reaction, and they'll likely present later worried about that suture material coming out of their skin or being permanently in there. And then after the procedure, a lot of times we do add steri strips, even if we use sutures, just to help further reinforce that wound. And then staple removal, so there is a staple removal kit. It works a lot better if you use that. As you can see, it basically creates pressure in the middle, and it allows those staples to be removed so they are straight when you remove them from the body. If you don't have those, you're going to try to use all these other techniques, and it's going to create a lot of pain for the patient. So if you don't have a staple remover, you should, probably find one. You'll notice this the most when you're like at your field training or deployed, and you had to bring all this equipment with you. So it's important that you guys actually inventory all of your MES sets prior to any sort of, forward deployed or training center environments or the field. And then wound infections. So this is something we obviously have to counsel the patient on. Any signs of wound infection, like I always tell mine, if it's like hot, red, warm, tender, you have any discharge from the wound, any fever, streaking, increased pain, you need to come back in. There's a chance for a wound infection. And that's usually going to be probably the most important step you need to talk to them about, so that they can hopefully avoid the infection, but they need to know those signs and symptoms so that when they come back, we can, open the wound, clean it out, may place them on antibiotics. If they have systemic symptoms, they might need IV antibiotics. And then wound care, you guys are probably covering this in derm, but you have your wet to dry dressings, your dry to dry dressings. Basically, you can place gauze in the wound. You usually want to cover all aspects of it. And then remove and repack it daily. This will be common like in your incision and drainages for your abscesses. You may have to place some sort of iodoform packing material in there. They have to come back every day to get it removed till the body creates that granulation tissue and the wound heals over. All right, and then we have our wound vacs. So these are, you're typically not placing these in an outpatient clinic. This will usually be done in the surgery service, and then they'll have to either be monitored in the hospital or have daily wound vac checks. We do have home health nurses that we can prescribe for them that come and change these. So this will typically be done on your guys' surgery service in your phase 2. You'll get some experience with these, but typically not be done in outpatient clinics or anything like that. And then silver nitrate. So this can be used for minor bleeding or to knock down some of that granulation tissue. This will cause tissue necrosis, and that's part of the normal process with these when you're using it. You also need to think about not closing these wounds as well. If you're using the silver nitrate, the tissue's going to slough off eventually and leave a flat surface for that epithelialization. All right, so you guys think you can suture now with minor procedures? Yeah, so we'll, when we're doing our lab, we'll show you guys those videos that are going to help you do those sutures, and we'll have plenty of staff there to help course correct you guys as you're performing those procedures. All right, what questions y'all got?